my career assignment for pharmacology, and my allied health specialty is going to be a registered nurse, home care infusion specialist. This is Julie, and we're going to talk to her about what she does for her job and all the questions we're needing to do for the interview. So, as I said, she's an infusion home care nurse, and what does that job entail for you?
So it's a home care position, so we go to people's houses in a designated area, and we take care of really any IV matters, whether it's administering medication, maintaining peripheral or central venous access, drawing labs, and then monitoring for disease progression and or illness.
And as always, you're correctly identifying your patient, following standard safety protocols, and making sure the area is aseptic, and all of the normal things you need to do in other areas of healthcare. So, like Julie said, the main things that she works on with patients and patient care would be managing intravenous lines, access ports, peripheral lines or PICs, and midlines. And she also can do sub-Q medication and occasionally intramuscular injections, depending on the medication. So, your different work settings. Julie specifically works traveling to people's homes, but a registered nurse, LPN, ADN, or a certified registered infusion nurse, or CRNI, can work in a hospital, or specifically working with oncology, rheumatology, and other departments that work with infusion medication,
Mm-hmm.
or work at a private practice or clinic, or do home care. So, what are your typical hours when you're doing home care, and how does that vary?
So technically my shift is 9 a.m. to 9 p.m., but that really can vary depending on patients' availability, if they work or if they have doctor's appointments. So my day could be done very early if, everybody's able to be scheduled really close to each other and live close to each other, or it could be a very long day if I'm waiting for people to get out of work and and be home from their appointments. So.
So, likely work hours and schedule, like Julie said, could vary depending on the day and the patients that are assigned for the day, and whether a last minute patient gets picked up, or depending on if scheduling just adds someone to your day. Usually she's scheduled from 9 a.m. to 9 p.m., but this could last longer, especially depending on how access for your IV site goes, if you don't already have a line set up, and if you do have a line set up, if you have issues with potential clotting or other issues that could go on, it might make your visits longer, or you may end up having quicker visits for the day and spending less than a 12-hour shift. But that 12-hour shift also can include, or does include, your driving time from patient to patient. So this could also go over depending on traffic or other life circumstances that go on. So on average, it may be a 12-hour shift, but probably could be more depending on what else is going on in life.
And another thing that can happen in this job too is that if things are emergent and or even urgent, we may have to send somebody to the hospital or to a doctor's office. Some of our job, even though we could be planned for a long visit or a long day, we could go out and find that the patient is in a situation where they need to go to the hospital, and we would, send them on their merry way.
So, the clinical and non-clinical job responsibilities and tasks are going to cover a lot of things, and specifically as a home infusion nurse specialist, what I researched, and then we're going to confirm with Julie, is that your specific clinical tasks are going to include basically everything that you normally would have to do as a nurse, and then add IV specific and medication specific, medication specific criteria. So all of these things would include, like I had said before, standard precautions, having a sterile area to work with, make sure you're cleaning the site and evaluating the site properly, making sure you know what medications and have the medications set up and are able to infuse and administer all of them properly, and also know how the medications work and what to look for when administering medications for potential side effects or potential reactions, and then also be prepared to treat for an allergic reaction or any other side effect that may happen during an infusion or while you're doing home care. So the non-clinical aspects and things you might need to do are obviously be proficient with computer and the specialized programs that your employer uses for documentation and keeping track of patient records, patient signs and symptoms, all their vital information through their EHR, and then also being able to communicate with your patient pre and post appointment. Also make sure you're good at scheduling and time management, knowing, at least attempting to know your route, where you're going for the day, because scheduling does not necessarily know where you're going, and even if they do, they're not taking the time to look at a map. So you should be able to plan ahead and double check things and be detailed oriented, and then also be able to use an iPad and all the other technology that people use daily. Obviously you need to be able to use a cell phone. You're going to have a work cell phone or another device that's encrypted that's for work documenting only. And then also, depending on the type of person you are, you might also keep your own paper copy of your notes before putting them in. So just making sure you know medical abbreviations so your documenting isn't getting corrected, or also knowing how to communicate with your patient maybe in a non-clinical way would be a good thing, and definitely one of the skills you need to have. But also communicating, because you're going into someone's home, you'll be communicating with someone other than the patient. So you'll be interacting with pets, which could probably be a little crazy from time to time, and then any other family members that may be present or want to be present. You may need to confirm with the patient that that's okay or not, like usual. And then I feel like, based on my research in a home environment, usually a family is present and also learning how to do whatever treatment you're providing, or is going to be present if a nurse is always needing to administer a medication. So you have to be, amicable. I can't think of the word right now. Flexible, I guess. Understand that the patient you're going to see all the time may not be in the best mood depending on the day. They also might be great. They may be easygoing, but you're going to always get varying personalities of patients. So
you always want to respect that you're in their space and that they are calling the shots, unlike when you work in a facility, and let them be more in control, even though you're there to do a service.
Right, and you're also, again, with the time management, you're also balancing based on scheduling. Sometimes scheduling, depending on the agency you're working for, may schedule patients and patients have to stick to that relative time, whereas other agencies allow you to schedule directly with the nurse, and you're moving your schedule around based on one patient does have a full-time job or a part-time job, whereas another patient is at home. And some patients are very flexible and other patients are not flexible and will only allow you to come to do care or service at one specific time, one specific day, or because it is a big impact on a patient's life. So you have to remember that when they're being specific or seem a little ornery, that really, you're providing care and treatment and you're going into their personal space.
Mhm.
So it's a lot of trust and a lot of one-on-one interaction, especially with the patient. So you build especially for ongoing care, you build a relationship with that person. So how would you summarize the basics of your clinical responsibilities or tasks?
At my job specifically, I'm actually employed by a pharmacy, although I do act as a nurse for that pharmacy. So my skills and roles are only with IVs. So although as a nurse I could do, say, wound care, I'm not allowed to assess or give any recommendations for those things under my company's title. So I need to very much specify my care to just what's going on with the IV, only the IV site. With that being said, if there is a wound in or around the IV, then I would assess it and include that. So we do everything, like I had said, giving
Cleaning.
medications. We really want to monitor these patients, know what the outcome of this medication is going to be, if they have an allergic reaction to this medication, initiating our protocol that we have in place, which includes giving like epinephrine, steroids, Benadryl IV. We manage central lines such as PICC lines, ports, central venous catheters, intrajugular lines, and epidural lines, where we give the medications through them, or we sometimes even with antibiotics and basic hydration, we teach the patients to actually administer those themselves. So they would say give themselves IV fluids 3 times a week, and then we would go out once a week to change the dressing on their central line for them. We also put in peripheral lines or PIVs, and we would come put one in. Usually in those situations we're giving a medication, and then at the end of it we remove that peripheral IV. And that way the patient isn't at risk for further infection, and also we're not at risk for them using their IV for anything that they're not supposed to.
I didn't think of that.
Yeah, so with that being said, if somebody needs IV therapy and they have a history of IV drug abuse, unfortunately, usually those patients need to go into a clinic setting and need to have a peripheral IV placed every day for whatever the therapy is, because we can't trust that they will not either inject themselves with drugs or risk themselves putting themselves into an infection, because usually a lot of these lines go right to the very tip of the heart. So any infection that enters that line can become septic or system-wide very, very quickly, and can put them at really serious health risks. The other things that we do is we draw labs, so then we have to go to a labs. We can either go to a hospital or an outpatient lab setting, and we drop those off, make sure that we've filled out the right tubings with the right information and the right lab slip, which we all have to do by hand. Let's see, what else?
So how does it work, for instance, if you have an issue starting a line or an issue during infusion that is not an allergic reaction or like life-threatening where a patient would need to go to the hospital, just something that you need to troubleshoot? How does that work?
So something like, say, if an IV pump is not working or an IV tubing is not working, we do keep extra supplies on us in our car on our person. So we would, try different tubing, try a different pump, change the batteries, things like that. If for some reason we were unable to get an IV in place, I work with a great company that, I could shoot out an email to my fellow nurses out in the field and see if anybody is around in the area or will be soon, and if they can come out and maybe take a look, because although we're all very good at IVs, we all do it very differently, so somebody else's technique may be better for that patient's anatomy. Luckily I have a really, really good support with my team out in the field. Even though I am working autonomously, I do have that support.
Okay, that's good to know. That's not necessarily something I thought about. So do you have a direct interaction with a patient's physician or their nurse practitioner, or does that communication go through your employment agency and you don't deal with that at all? Like, who do you interact with other than your in-field nurses you may need to reach out to for assistance on a specific patient care?
So if patient either has an adverse or just a regular or anything type of reaction to a medication, we would definitely report it to their prescribing provider, especially if it's something that needs to be monitored ongoing. And say they're a monthly patient, we want to make sure that somebody's going to be following up with them within the next few days. The other is that we interact with the lab very directly. And then the other thing is with providers is sometimes we'll go to a patient's house and they'll say, oh, well, my central line was due to be removed today. You know, are you going to do that? And I wasn't expecting that. And so we say, hold on just a second, and I can call the doctor. And if they confirm that indeed they did want that line removed today, I can take a verbal order and remove that line. And then again, teach the patient how to care for the site and make sure that everything is done safely and septically.
Okay, and so that would be for a peripheral line or a PICC line
Yep.
or a central line?
So yeah, so that's a good point. So we only remove peripheral IVs and peripheral central lines and port needles. If it's a central tunneled line, which is another semi-permanent line that goes in through the chest, that one actually needs to be removed by a physician in an office setting. So that's the only one that we don't really mess with. And then the port is obviously, we can remove the external needle, but the other part is internal. So if there was an issue with it internally, they would need to go to a hospital to have that dealt with.
Okay, and as a traveling home infusion nurse, you wouldn't do PICC line insertion at someone's house. You would only do, that would only be done by a specialist in a hospital or clinic setting?
So no, actually there are nurses who are trained. I could have been trained and I chose not to, but so we do have some nurses on our team that can go out and insert PICC lines, so peripherally inserted central catheters, or mid lines, which are inserted the same way but just don't go up into the heart. They just go up into like the shoulder area. But the patient can also go into the hospital, and in those settings even they can be done at the bedside or under radiology.
This is cool info.
And then they, with the lines that go up to the heart level, they can either do an x-ray to ensure that it is in the right place, or they can do an EKG to make sure that there's no irregular cardiac electric impulses that are being caused by being tickled by the line in the sinus node.
She's very knowledgeable. So one of my questions I want to add into our required questions is what type of medications are you giving patients at their home? From the info I looked up, it's just intravenous, which means or subcu or intramuscular, which could be a lot of things, but in your specific scope of practice and through your job, what are the most common types of medicines that you're giving to patients?
So I would say the very most common is probably antibiotics, and in those cases we're mostly teaching the patient how to give them. We'll be there for the first dose, make sure that they don't have an adverse reaction, teach them how to do it, and then they kind of, take it off from there and they maintain their line and give themselves their own medication every day. We do a lot of hydration for chronically dehydrated people or people with health issues that are triggered by even mild dehydration. We do chemotherapy. We do IVIG, which is intravenous immunoglobulin, which is a blood protein to help people with poor immune systems, to give them an immune system. And then we give biologics or anti-tumor necrosis factor medications, which reduce someone's immune system for an overactive immune system like Crohn's disease or rheumatoid arthritis. We also do give, not as often, but we do give cardiac medications, inotropes, like milrinone, to help with poorly functioning hearts. A lot of these patients are on a maintenance dose of these medications, waiting to get a heart transplant or a ventricular device inserted.
Okay, so like you said, some examples of the medications, like for antibiotics, would it be like Rocephin, or what are a couple of the names of medications for an antibiotic or rheumatologic or cardiac med? I don't know if I missed you saying that, or a chemo med.
So we give a lot of the broad spectrum antibiotics, a lot of vancomycin, a lot of the Rocephin, like she said, because usually these patients are having bone or blood infections because they've gotten so bad they need to go home on these IV medications, and there's not really any other indication for them to stay in the hospital. So a lot of times they're on these much stronger antibiotics that they're having multiple times a day. The cardiac meds are usually like milrinone or dobutamine. I would say those are probably the two most common ones that we give. And then as for the other meds, a lot of them are just brand name changes, but they're very similar meds like Remicade and Flectra, Infliximab. They're all the same person really, but they're just under different company names. And same with the IVIG. There's GammaGuard, Gamunex.
Right, they're just a different concentration, a different percentage of the IgA.
Yep, and
or IgG.
Yeah, different preparations of it, but they're essentially the same medication.
And all those medications will have a different pre and post care, or
so usually,
different times or infusion rates.
Yep. Usually we go by how the patient is tolerating it, and we also generally the protocols for how to give them are the same for the type of medication, not necessarily specific medications. With that being said, though, there are some of them that are essentially the same medication, but they need to be mixed or prepared with a different substance, whether it be being mixed with normal saline or a sterile water. And that's all indicated either under our protocols or under the package insert for the medication. So we actually reference both of them, especially when you're learning, to make sure that you know how to prep the medication properly, so that it is not wasted, because these medications are unbelievably expensive, anywhere, some of them like $10,000 a bottle plus. So a lot of our therapies, are costing the insurance and the patient a lot of money, so we don't want to be wasting anything by improperly mixing it or using it.
Okay, so I think we covered a little bit of this, but education requirements, like I had said, you have to be a registered nurse. So you could be, have an associate's degree and be an RN, be an LPN, and have specific credentials for most of the areas of IV infusion nursing, or get further accreditation as a CRNI. What education do you have? I know you have a lot of extra certifications and things like that in addition to your RN, but you did a bachelor degree in nursing and have a BSN, and then have special training through your company. Depending on where you're employed, you're going to do company-specific training as well as follow national and state guidelines for infusion nursing. And then you have to do continuing education credits every year for a certain amount. It depends on the state.
Yeah.
So it's like 40 to 60 every.
It's actually 15 every 2 years in Massachusetts, which is where I'm from.
But maybe they give you more credits for assignments. What I was reading was.
A lot of times our companies have us do, like she said, the training and stuff, and there will be credit units on that also, so we do get more than that.
So you do have to keep up with current guidelines, and then also do some continuing education material pretty regularly, just to make sure you're up to date, but also you're interacting with patients pretty much on a daily basis, and then both within the care setting and then pre and post care. So there's a lot of patient interaction with this job, whereas in other specialized professions you may not be doing as much communication, or have to relay information in I'm trying to think of like a layperson terminology, whereas I'm trying to think of how to say it, like in a hospital and you're not doing continual care, you may not have to think about the way you're phrasing things or the way you're explaining things for long continued therapy.
Yeah.
If it's just acute and you're doing one thing, you're in the ER and you're fixing a broken bone, you're throwing on a cast, or doing all of the things up to that, or the patient may not even be conscious or understanding enough what you're saying to be able to explain something, whereas with this type of care you have to be able to teach and then understand at an individual level and adapt the way you interact with people based on someone's ability to learn or what they're doing each day.
So knowing that what their history is, what their educational history is, what their job is, things like that are really important, because sometimes if you'll have a nurse or a doctor for a patient. They don't really want to hear all of the things that you have to say. They know better and they just want to get moving. And then there are some people who unfortunately are not as educated or do not have that level of functioning of their brain. So you really need to simplify things and say them in a way that they understand. We also provide written instructions. We provide videos online. And then we also will even bring extra supplies so that we can demo and play with the supplies to make sure that the patients are performing their therapy aseptically.
So do you work with patients that are just a certain age?
No, I do all ages. I've had them as young as 1 month and as old as 90 something in this age. So we do have babies with central lines that are getting antibiotics or hydration or whatever they need. As long as somebody is either able to be there and administer the medication, such as in a child's situation, it would be the parents, or if it's somebody who's very old and isn't either altogether there or doesn't have the dexterity to perform the tasks. If they have a daughter or loved one or whatever, that can help out. So the biggest thing though for my job is that they can at least do some of it themselves and understand what's going on, and so that it is safe to do it in the home.
Okay, and then my other job specific question for you is, like you said, how do you work? I guess it would be like under pressure. Like I feel like I would be a little bit nervous getting sent out to a 1 month old, but I don't have nursing experience, which is why I'm sure they wouldn't send just anyone. But how do you handle getting assigned to like somebody who's very old and a little bit more frail, and 1 month old who also is just different than dealing with somebody in my age bracket? I'm a little bit more hardy.
I do have experience in the emergency room, I'm pretty calm under pressure, and I love the experience of learning and kind of being under pressure, I guess, even. That part doesn't bother me. And then as for like going in, I still, I think I'm always nervous with a baby because they are fragile and frail. So for me, a way that it helps me to, I guess, calm my nerves is to ask more questions of the parents when I'm on the phone with them the night before scheduling the visit. Asking them exactly what happened in the hospital, how is baby doing, what did baby like or didn't like, should I be bringing, supplies to make the adhesives come off easier to prevent the baby from being upset as much. Asking more questions and getting to know what the family wants and letting them know what to expect from us, I find really helps to kind of alleviate a lot of that pressure, because most people are nervous and or bad things happen when there's a big unknown, so trying to prevent a lot of that and preparing for the worst and hoping for the best.
Okay, so let's see, another question on here is salary range. I'm not going to ask you about your specific salary, but I did some research, quick research, and according to salary.com, an average salary for an infusion nurse is around $80,000 or so, but you have to take into account that this is going to include your regular hourly pay, which varies based on state, and then also is going to include any overtime, and it doesn't really specify as this is including what you're being paid mileage or reimbursement. That also may vary on state, and then if you're traveling from one state to another in and out of state, and how all of this interacts.
And the other thing is that we also get paid by our years of experience and experience in that field specifically, so that there can be quite a big variance between two people at the same job just because of time and experience. And if you're training other staff and things like that, you get more, and then managers obviously get more.
Okay, and there are differing license, certification, and registration for infusion nurses, but like Julie said, she's just a very experienced RN and does not have a CRNI. That isn't necessary to be an infusion nurse, but some nurses do go on to do this and do an additional 1,600 hours of infusion specific training, and then an exam through a number of accrediting organizations, but those are all overseen by the NAAC, and some of the associations are the Infusion, Infusion Nurse Society, National Home Infusion Association, and then there's a few others. So one of the questions we have to also discuss is what you learned from research compared to what I thought. Well, what I thought was based on my personal experience of having home care nursing for all of my adult life and most of my adolescent life. So I have always been getting IVIG treatment. So I've had a home nurse most of my life. Was weekly or bi-weekly infusion treatment, and I have done this as well as antibiotic treatment through a peripheral line, and also have had intramuscular injections of antibiotic, and have done IVIG with just a peripheral line being started each week, and have also done treatment with sub-Q IV. So this was my personal experience and why I chose this specific specialty. What I learned about my research, I guess I didn't really think about all the varying areas that an IV nurse could work in. I mean, I knew they could work in a hospital or home or clinic, but doing more detailed research and thinking about how you could be oncology specific and just be working with chemo medication, or only be working with very specialized specific like heart medication, whereas in Julie's area of work, she's doing a lot of traveling and has varying patients, so she's not specializing in one type of treatment or area, and has a more broad overall knowledge of what to do with different types of meds, and it includes a variety of things, like she said, as something as simple as cleaning a site and pushing saline to make sure it's not clotting, or doing chemo or heart meds. So I guess I'll ask you the same question. Like, what the job that you have now, is it what you expected when you started doing infusion nursing? Did you even know infusion nursing was a thing when you were becoming a nurse?
So when I was becoming a nurse, I had never heard of it. I was actually, had been a nurse in the hospital for 8 or 9 years, and this hospital setting was becoming very stressful for me, so I was looking around at my other options, and the hospital that I worked for at the time had an infusion company, but I had never heard of such a thing. So I actually did a little bit more diving into it, and it sounded like a really, fun, rewarding, and much lower, stress and intensity than working in the hospital type of job. So when I found out about it, I was like, wow, this is perfect. So I've been doing it for the last 7 years now. I really love it. But no, I had never heard of it before.
And this is actually the area of allied health that I'm wanting to go into when I finish my BSN and have had some work experience. I'm hoping to go into home care, and then after doing home care or shadowing, doing hours of nursing, that I'll be able to do further training and either do infusion care or more specified, specific one-on-one care with patients, but doing traveling nursing in the home setting. I'm not looking to do emergency room or very high
Acuity.
Yeah, or very high rate of patient. I like one-on-one patient interaction. That's always where I've done my healthcare work. And so for me, I think the qualities that you need just to be a home care provider of any kind are definitely adaptability, flexibility, being understanding and empathetic, and also being personable and being able to communicate effectively. Like if you're having a bad day, you got to be able to shut that off, right? You know, take a minute when you pull into someone's driveway or whatever location you're going to and reset and think about the way you're presenting yourself and just remember that you're providing care, especially in someone's personal environment. So being able to adapt and troubleshoot, understand the equipment, like I don't know if we had mentioned that you may be using an IV pump, but in most home settings you're starting your own line and probably using gravity. But there are other specialized equipment that you may use for IV infusion or other central line or peripheral line care, other than catheters, needles, you know, paper tape, alcohol wipes, all the things that you would be checking on, double checking, make sure they don't have, make sure they have current dates, aren't expired, are prescribed to your patient, and your patient is the one receiving them.
Mhm.
Are there any other special equipment or devices that you specifically need to use in your, like daily patient care?
Well, definitely devices to manage and monitor vital signs, so your blood pressure cuff, your stethoscope, your thermometer. Those are all things that most of us, I would say, provide to ourselves, but you can get them provided by the company. They usually will provide you with anything and everything that you need, including the stock in your car in case something is not delivered appropriately. But knowing needle sizes and what needle size is appropriate for what size patient and what size vein, and then the dressings and knowing, for certain skin types, which dressings are appropriate, something simple like that, any type of reactions that somebody could have to that, and then knowing how to use all the different pumps that we use, anything from, IV pumps to subcutaneous syringe pumps and things like that, and how to troubleshoot them and knowing when to get a replacement.
So what would you do, for instance, so you would learn how to do this, right? You would learn how to pool IVIG, which the reason I'm mentioning this is because I have experience with this. What would you do if there's an issue with your IVIG bottle or the way you're pooling med? Like the pop falls off of the bottle, or IVIG starts going everywhere.
So, for a lot of these reasons, we actually don't pool IVIG anymore. We have to give it via the vials now, so that those things don't happen, because those are all huge risks for infection. So now we actually just directly inject the IV tubing into the bottle or vial of the immunoglobulin, and give it directly that way. And therefore usually use a pump because the bottles can slow down the infusion rate if you're just going by gravity. But yeah, so we don't actually pool anymore because there was so much risk for infection in these patients who are already immune compromised.
This is excellent like on the job info. So my other question is, what would you do if you realized you made a mistake, even though this is very unlikely because you're very thorough?
Well, a lot of times, mistakes happen, unfortunately, and more often than not, there's no harm to anyone. So, admitting that you've made a mistake is, a big way to honestly earn trust with people, that you can fess up to things that have happened, acknowledging that it's happened, reaching out to your superiors or managers or whatever, seeing what the next step would be. Obviously, if there was any adverse effects or risk of adverse effects, doing what you can to resolve it, and also notifying the prescribing physician that an error has happened, so that they can, again, also monitor and address any issues that could have happened from it. But I would say the biggest part is probably just communicating this to the patient, that an error has happened and that you're going to do everything in your power to resolve it.
Right, so we're talking about home infusion, but in other areas there's room for horizontal or vertical movement in your job as a infusion nurse, and some of the areas you could move to still within like the infusion realm or other areas, including like supervisory or managerial departments, could be a clinical nurse specialist or a nurse practitioner or a nurse, an nurse anesthetist
Mhm.
or nurse anesthesiologist, among other things. But that was one of the questions that we were to address, and also talking about room for growth or not job security, but the outcome or outlook for the job is from the research I did through 2030, there's about an 9% growth rate specific for infusion nurses, but nursing specialty in general, just nurses in general, has a very large growth expected between now and 2030. I think the statistics I saw were 20% or more. So within the realm of nursing, there is room for growth, and job security looks pretty good. And then the last question we're going to talk about will be, how is the understanding of pharmacology and the body systems relevant to your area of specialized allied health? And I'm just going to start with my info, and then we'll wrap up with Julie's input on that. So, in relation to pharmacology in our class, understanding the specific route of administration is important, obviously. So that is mostly intravenous, but like I said, could be subcutaneous in basically IV administration of medication, and then your sub-Q admins are just under your skin for absorption over a certain amount of time, and then intramuscular injection of medication, and understanding how quickly the medications are absorbed, what medication you're giving, and how long the effects of the medication as well as potential side effects can last, and then what to look for signs and symptoms of potential negative side effects or even allergic reaction is definitely relevant to the pharmacology and how the body systems work. But you're going to be administering into the venous system, and then you have to have a general understanding of, you know, veins, where to go, how to start align the circulatory system, and then pretty much all of the other systems, including, you know, cardiovascular, respiratory would be the main ones, and then any potential neurological or other immediate, like acute side effects, or any side effects you may need to follow up with the patient about over the next day or two or week. It depends on the dose of the medication, how often the patient is getting the medication, if they're an ongoing patient, and then when follow-up is with their doctor or with you. So checking on those things and understanding the process of how the medication works in the body, and understanding your patient and what other things they have going on, and making sure that you confirm their medical history, even though it's probably annoying for you and the patient, but re-verifying that they've not added anything to their treatment regimen, even if it's a vitamin or something else like that, because certain things could interact with a medication more severely than others. I can't think of an example off the top of my head, but there are even vitamins that would interact with something for blood clotting or cardiac meds, or just certain things you shouldn't be eating or doing or ingesting while on medications, or you may have a more maybe more likely to have a reaction depending on other factors that you have. You know, like I said, with other meds or food or really anything. So just being diligent about details and checking with your patient, and just clarifying, going over, and making sure you understand what you're giving, why you're giving it, and who you're giving it to, is really important. And then making sure you're not giving an expired med, and that, you know, there's just no potential, that alleviates the potential for any negative outcome. And overall, your patient will have a better quality of life if you're doing the steps you need to do your job properly. So, what do you think about understanding how pharmacology or the medication you're giving and the body systems interact with your patient, and how does that interact with your specific specialty?
So everything that you said is definitely super duper important. Other things that are important for pharmacology is we do a lot of reconstituting medications in the home, which is mixing the medications up and getting them ready for infusion. So knowing, that doesn't need to be mixed with sterile water or saline, and how is it going to affect it if I, use the wrong thing, and why it's so important to use the right thing. Also, when you're giving the medications, for example, the immunoglobulins don't react well with saline being infused at the same time. So knowing that if we're going to be giving fluids at the same time, it's usually going to be a dextrose infusion, and knowing things like this so that you do not either adversely affect the patient or waste the medication if they're just negating each other. And another thing I think that's really important is knowing what the expected outcome of the medication is. So, for example, let's just stick with immunoglobulin, that this is supposed to be improving this person's immune system. So if they were somebody who was getting a lot of infections, or having a lot of issues with their nerves that were damaged, seeing some positive and forward movement in these things, and if they are not having that, to notify their doctor so that they can discuss possibly other treatments, increasing the dose, changing the medication of a similar genre, or stopping it altogether if adverse effects are impacting their life more negatively than the disease itself.
And this is also important for patients getting insurance approval or not. And then, like, what would you need to know about different body systems in relation to the medication you're giving? Because I know you mentioned you give some medications that are for patients who are having severe heart issues, or chemo medications, and you've mentioned immunoglobulins for immunocompromised patients, and just hydration and other things. But specifically with the different types of medications you administer most often, what do you need to know about the different body systems?
I guess you need to know how it's going to affect each system, and you need to be able to relay this to your patient so that they can also monitor for the, we'll say cardiac meds, so that they can, evaluate themselves when we're not there for, shortness of breath, any coughing, any swelling of their extremities, make sure that they're monitoring their salt intake. A lot of it is educating the patient so that they can also be keeping an eye on their situation when the nurse isn't around. But we also want to be checking all of these things every time that we see them, so that we can make sure that this therapy is being effective for them.
Okay, my last question for Julie, since I explained a little bit about why I would want to go into this area of work, and she did mention, working in the ER and that kind of pace, and after a lot of years working there, it was just wearing her out, and she needed a change of what she was doing to provide care. So you thought that infusion nursing seemed good, like a good other option for your nursing career, but what made you choose specifically this allied health profession?
The reason that infusion nursing was so appealing to me was that probably probably primarily was that you are dealing with one patient at a time, so I can give this person my undivided attention. I can get to know them. I can get to know what they like, what they expect, and I can really cater and individualize all of my visits to how the patient wants to be treated and all of that. And then with that being said, it does not happen very often, but if you were to have a begrudging patient or a more difficult patient, you do have time in between patients to decompress, to, get it out of your system or listen to some music or a podcast or something in the car on the way to your next one, so that you're completely decompressed and you're ready for the next patient, and you can be emotionally and physically more attentive to each patient and give them the time and the patience that they deserve.
Okay. And, is there any tips or tricks or bits of advice you would give any other students in this class who hadn't thought about going into, since this is pharmacology, I'm not sure what everybody else in the class is doing, but like I said, I'm trying to get my BSN, and if people hadn't thought about doing a more specialized infusion, being an infusion nurse, traveling, specifically home infusion nurse, other than be prepared for driving or potentially long driving or working even out of your regular state depending on where you live, because I live in Connecticut and she lives in Massachusetts, but you can get from one state to the other with a few hours, or depending if you have certification or temporary certification for a state, depending on availability of nurses or who is your pharmaceutical provider or nurse agency, they may send you out of state. I know that may not be relevant to your current position, but it has been in the past, and they can send you to like Maine, New Hampshire, Rhode Island, Connecticut, Massachusetts, depending on the company or overarching agency or pharmacy that's sending out the meds. And other than having lots of driving or potential for driving and long hours, even though you're able to have breaks in between, is there anything else that you think individuals should think about when determining whether this might be a good path for them?
I guess what I always go back to is that I think anybody fresh out of nursing school or trying to figure out what they want to do should work on some type of a medical surgical floor where you can see a little bit of everything, do a little bit of everything, see what you like, see what you excel at, see what you don't like. So for me it was finding out that 47 call bells going off and everybody calling your name at the same time was a little too much for me. So I was able to see this worked well for me. Also, I exceed at IV insertion, and I very, very much enjoy it. And I enjoy being good at it for my patients so that it's less traumatic for them. But this took me a few years in the hospital to figure out what I liked, because you can try and do a little bit of everything in the hospital. So I think everybody that's starting out should see what they like, because some of people think, hey, I thought I was going to work in the ER in New York City, and nope, don't want to do that at all. So, you learn once you're in the field what's really good for you. So I think it's really important to be honest with yourself and to try a little bit of everything.
And be prepared, especially really in any area of nursing or healthcare, you need to be prepared for
The worst.
Yes, and also things to change very rapidly. Even though in the environment we're talking about, it doesn't usually happen. Emergencies can happen in the home, even if it's not related to the IV, right? It's a family member. There could be, you're in the home, so there's a million different things that could happen. So knowing what type of person you are, and knowing that what type of area you may fit into based on your personality, your attributes, things that you're good at. This is why I would be good at one-on-one home care, because a million different dingings in an ER with the traumas coming in, it's not for me. I already know that, but I'm also not a regular undergrad age, and this wouldn't be my first degree. So there's some life experience that's happened in there. So I have done home care. I know a lot of the things that can go on, but not specialized home care. I've worked with very specialized patients, but not in a specific nursing scope of practice, in other healthcare provider scope of practice. And overall, I think this seems like a good fit for me ultimately, but home care in general, one-on-one with the patient, is more my speed. And so this is my career path interview, and the awesome Julie was my amazing special guest. And I think that we covered everything. I know it was a little long, but hopefully this gives all of you some information and an idea of a potential nursing path if that's where you're going, or even if you're doing pharmacology to become a pharmacist, understanding the different areas of where the medication you're dispensing, or if you're going to be a PA or a doctor, like the medication you're prescribing, the other areas of allied health that go into each aspect of patient care. But ultimately everything is coinciding, wrong word, but everyone's collaborating to give hopefully the best possible outcome to the patient. So determining how you best fit into that, and your qualities and your skills, even if you're just starting out, understanding who you are is probably the best first step, and then you're able to better get your patients on the right track and give them good care. So that is the conclusion of my career path interview. Thank you.
Thanks.